actually a professor of international health at Case Western, and actually I'm on the ground doing research on malaria and actually neglected tropical disease, lymphatic filariasis, schistosomiasis, and hookworm. And I've been working in the coast of Kenya for about 20 years and also in Papua New Guinea, and I go there 3-4 times a year. And one of the areas that I particularly work in is in pregnant women and young children. And I just came back last week, in fact, from going to the antenatal clinics we do in Kenya. And all the women come in, the first presentation, when they come for the first antenatal clinic visit, and we screen them to see if they have different infections. And invariably, they have hookworm infections, they have schisto infections, many have malaria, they have other kinds of intestinal worm infections. It's amazing, and they're all very anemic. And so the idea of just treating one just makes no sense at all. It makes really sense that we really do things combined. And because of the program, we have programs that are available to hand out medications to treat the malaria, but there isn't good programs to give to treat the intestinal helminth infections. So we provide free medication for intestinal helminth infections, but not free medication for the worm infections, at least into the current programs going. So those are changing, those have become available. It makes obvious sense to treat them all at the same time. And the same thing when we go into in the follow-ups, when the children get sick, they come into the clinics. The programs are available now to treat for the malaria infection, so they get the malaria infections. But when they go to the pharmacy, there's no other free medications. They have to pay for the antibiotics. They have to pay for the antihelminthic drugs. They're not available through these programs. It just makes very simple sense to have these drugs available to those clinics and those antenatal clinics that would then be able to distribute it, just very much like the savings you're doing. But it's such an obvious thing, and you sort of say, why aren't we doing this? Why isn't the places in place? And it's very frustrating that these resources aren't available. The same thing for the diagnosis. It's the diagnostics or the surveillance are done by the laboratory technicians. We need to get a better way of training them. We train them how to do good malaria diagnosis, but to train them to do good stool examinations, train them to do the other kinds of tests, and to maintain that infrastructure to do it. So their overlap is just incredible. And the women are multiply infected, the children are multiply infected, and so integrating these programs is just an obvious sort of thing to do. And then in a logistic place in Papua New Guinea, it's such a challenge to get out. It's such a remote area. There's really very little health structure system. So to get everything out there, you've got to bring it out to all these different villages to bring out the bed nets. And we're in the process of distributing bed nets. But that's for the malaria program. But we work on lymphatic filariasis. So the fact that these bed nets are coming out to work with filariasis is a real added value. But we should be bringing out antimalarials as well as antihelminth drugs at the same time. So these integrations just make obvious sense because they're not independent diseases. People, children, women, everybody are multiply infected with these things, and we really have to work at them together. So it just makes an obvious sense from that point of view.